Yes, I think we can start.
Sir.
Agree.
So you are not an IAS on?
I'm here. I'll leave tomorrow.
Okay, sir. Okay. Both Siddharth sir and me myself are there on the.
They already. Sure. Yeah, please start. Sir.
Yes, sir.
Please.
So, greetings and a warm welcome to all the dignitaries present here. I'm Sremshi from Planet, serving as the allocated station assistant to ensure a seamless experience. Planet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Planet serves as the digital partner for this event hosted by the Indian College of Anesthesiologists. And the focus of today's session is from OT to OPD. So let's begin today's session, for which I would like to invite Dr. Mukul Kapoor sir to take over. Over to you, sir. You can proceed with the talk.
Thank you, Shashi, and thank you, Clarnet, for hosting this program. And on behalf of the Indian College of Anesthesiologists, I would like to welcome all those who are online right now and all people who will later on see this webinar video on the YouTube. And let me talk a little bit about the Indian College of Anesthesiologists. The Indian College of Anesthesiologists is an academic body which has been running for the last many years. And basically, the aim of the Indian College of Anesthesiologists is to provide good quality education and also uh, uh, undertake examinations which will certify people in specialities and subspecialties. So, Indian College of Anesthesiologists has been very active in this field, and over the years, we have been running multiple fellowships, which include fellowships for critical care and fellowships on regional anesthesia. We also run fellowships for obstetric anesthesia and also fellowships for palliative care, among other things. There are other also fellowships running like the cardiac critical care fellowship, the cardiac anesthesia fellowship, etc. We have got a large range of fellowships and running in specialities and subspecialties. So we have been taking a lot of interest in the education of people in this country. And that, if you can see, the name of the college is also Indian College of Anesthesiologists. Apart from this, the Indian College of Anesthesiology has got an established place in the publication world, in the academic publication world. And we have been running the yearbook for more than 15 years now. The 15th edition of the Yearbook of Anesthesiology was released a few months back. We also run a journal called the Journal of Indian College of Anesthesiologists, which is called as in short name by JICA, which is published by Waterclover, which is getting slowly established in the field of medical publications. The Indian College of Anesthesiology also, in addition to, because it's a trust, it is in addition to this, is also doing some NGO work. We are helping a few NGOs so that we can help the poor and the needy at times. So we have been continuing with this webinar for on 5 years now. And the first webinar was held during the COVID times. And ever since that has happened, without fail, we have always conducted a webinar on Wednesday from 7 p.m. onwards. And this is an achievement by the Indian College of Anesthesiology, which I feel probably is a world record, that no webinar till date has run for such a long time. And today we go to another aspect of anesthesiology, something which is happening now in anesthesiology, something the anesthesiologists who are known to be just occupants of the operation theater, who are always bound to the four walls of the operation theater, have now gone out of the operation theater and are now performing very well outside the operation theater. And one of the pioneers in this field is Dr. Siddharth Verma. Dr. Siddharth Verma will be talking about our journey of the journey of anesthesiology from the OT to the OPD. And this journey is basically involving the conduct of pain clinics, the conduct of pain therapies outside the operation theater. And I know Dr. Siddharth Verma for many years. And Dr. Siddharth Verma, apart from Siddharth, can you share your first slide, that is your introduction?
Yes, sir.
So you can all see his achievements from this introduction slide. But let me tell you, apart from his achievements in the field of pain medicine, he has got great achievements in the field of electronics and communication, because he is an entrepreneur and he also runs web services of a number of professional associations in this country. Siddharth Verma is today a professor in anesthesiology and pain medicine in Bombay. And apart from that, he runs also what he has named as the Mumbai Pain School. And this is one of the achievements. And he has been he's been very regular in training and running courses for people in the field of pain medicine. And I think one of the most active persons as far as pain medicine is concerned, especially in web teaching and many other areas of teaching. So, Siddharth, I would say, has got great achievements, and he I just saw that he's also got some fellowships from Spain and from the USA, fellowships in pain practice from the USA, and I also got a European diploma in pain medicine from Spain. So over to you, Siddharth, to deliver this talk on from OT to OPD, the expanding role of the anesthesiologist in pain medicine.
Thank you so much, sir. Thank you for the kind introduction. It's indeed a pleasure to be introduced by a senior and well-renowned personality like you, sir. Thank you for the kind words, and it's my proud privilege to deliver this talk on the platform of Indian College of Anesthesiologists. And it's a topic which is very close to my heart, and I feel after today's talk, I think it will be a little more easy for people to understand, our colleagues to understand what is happening today. As sir mentioned, that we are now also entering this field in a very big way. In fact, we have established DM courses, FNB courses, etc. So it's coming in a very big way, and just think about the patients who are being helped by this resurgence in this field of pain medicine. So greetings from Mumbai. This is Diva Patil Hospital where I work in Navi Mumbai, and this is our team of past and present fellows in pain medicine who have completed their full-time fellowship, which we run a 1 year full-time fellowship in pain medicine since last many years. So before I begin further, I'd like you to just go through this reel, which is very common and popular. So I can go on and on and on and on. The key is the simplicity. And I think I'll go on with this theme, the invisible doctor. So traditionally, we as anesthesiologists have been working as the invisible doctor behind the scenes. And we are the doctors without whom probably things would not have been possible in terms of conducting advanced surgeries, and the patient. The problem is that you get a very nice surgery done, and patient wakes up pain free, and he has no pain. Surgery went well, and of course, the patient never asks for an anesthesiologist. Where my anesthesiologist is there? He always asks for, where is my surgeon? I want to thank him. So it's always the case. Although recently we have started running a very good pre-anesthetic clinics, and a lot of critical care settings, we have been involved in a good way, but then still the story remains the same. For Let's not talk about the patient, but even for the hospitals, even though as anesthesiologists we may be the most important part of a hospital, but then we are still considered as kind of a replaceable commodity rather than a quintessential service. So that's what the situation is in most places. And what I want to focus on is that pain connects this OT to OPD theme, and how it does. I will also explain through this talk. And before we begin and go further, let's learn a little bit about the pain. What is pain actually? And pain is nothing but it is an unpleasant sensory and emotional experience which is associated with the actual or potential tissue damage, or it's resembling that associated with actual potential tissue damage. So that is the definition, which is the revised definition of pain. And you will be confused with all these terms like associated with or resembling that associated with. So the reason for this is it is still very difficult to define many types of syndromes which happen with pain, and science has not been able to provide a very clear answer. So to include all the various types of pain, this definition has been updated. And to explain this further, pain is always a personal experience. So that means your pain is always different than my pain is different than somebody else's pain. And in addition, we have the pain and nociception, which is a different phenomena. So nociception is, for example, I give you a pin prick, that is nociception. But then pain, what we are talking, it cannot be inferred solely from the activity in sensory neuron, and one has to have the central brain experience. So pain is basically an experience as mentioned in the definition. So this is very important to understand. The third thing which I want to emphasize is that we need to learn pain. Okay, so we are born with a sensory system, which also keeps on changing and maturing as we grow up. But in addition, through our life experiences, we learn the concept of pain. A simple example can be an infant when they go first time, the mother or father has to teach them that, okay, this is hot, don't touch it, otherwise you get burned. And hence, all these life experiences, they will change the individual's concept and perception of pain. The next thing is that the person report of an experience of pain should be respected. So this means if person says he is having pain and we get a normal MRI or a normal finding, so we should not refer them to psychiatry. Rather, we should try to understand that what is the problem, and more often than not, we'll find that there is some underlying problem. In addition, pain, although serves as an adaptive role, it is protective by nature. If we had no pain, imagine we'll go near the something hot or something cold and we'll damage our hand, we won't even know. So it is a protective and adaptive role, but it can also have adverse effects on function and social and psychological well-being. Imagine having a headache throughout, and you not being able to do anything, but when you go and get all your tests done, everything is normal, and you are labeled as some vague form of headache, and you are reduced to just a classification, and then you are left to battle it out alone. So that's very tough. In addition, verbal description is only one of the several behaviors used to express pain. And you will see as anesthesiologists that we are also very much active in pediatric pain. We are now having big pediatric pain conferences, which I think some of you are already attending. So earlier we used to think that the younger kids or infants, they don't sense much pain, but then that has proven to be false long ago. And if they are not able to express pain or communicate, that does not negate the possibility of their experience of pain. Okay, so let's go on to understanding pain today. So pain, as I mentioned, is sensory plus emotional plus psychosocial. So psychosocial means that imagine a patient walking into my OPD with their husband or wife, and the person who is suffering, they are explaining about their pain, but the other guy, they are just indifferent to it. So they may say, oh, I have taken them to 100 different doctors, and everybody says she's normal or he's normal, and but he's saying or she's saying that they're having pain. So that's the psychosocial component of it, and it's like a really important part of the pain story. The next thing which I want to emphasize is that pain can be acute, subacute, or chronic. So acute is usually 4 weeks or less, subacute is 4 to 12 weeks, and chronic is more than that. So you can see and understand that this is a very important phenomena to understand, because it's not just time, but rather the treatment itself changes. We will treat acute pain with different kind of strategies and drugs and techniques, whereas we treat a subacute or acute on chronic or chronic pain totally differently. Even the drugs which we use are totally different. We will not use, say, gabapentin to manage an acute pain, which is due to nociception or nociceptive pain, whereas we will definitely use it to control neuropathic pain or chronic pain. So that's something which we need to know. Then comes something which is known as central sensitization. That means that the this person who is suffering from pain, he's overtly become sensitive to pain, and if they don't need the stimulus anymore, and now they can self-sustain the sensation of pain, and even less than normal stimulus is able to evoke pain. So all these phenomena are categorized under sensitization. It can be central or peripheral both, but these are complex and complicated phenomena which we need to understand when we are treating pain. Now, why it matters to anesthesia? So, I'm very sure that this notion of invisible doctor is about to change. Now anesthesiologists are even more and more going into educating the patients, the other doctors, even the surgeons about what they do per se. But pain is a different story altogether. Pain is all about awareness, because once patients know about you, then only they can come to you and get treated for pain. So pain impacts the recovery, ICU stay, mobility, complications in general anesthetic practice. But that's not what I am talking about. Uh, Acute pain is our core strength as anesthesiologists. We all very well know that the components of anesthesia include analgesia, which is very important part of a balanced anesthesia. So pain management is the basic, you can say, role or the basic component of all our anesthetic practice. However, that's mostly related to the acute pain when we practice that, which is our core strength. Even the acute pain has gone a phenomenal evolution. We have acute pain service which has evolved from rudimentary practice to now a physician-led, nurse-administered service, which is being widely practiced by many institutions now. The ERAS protocol for the enhanced recovery, and the various blocks, patient control, analgesia, epidurals, they have transformed the practice of an anesthesiologist. And a modern anesthesia quality indicator, it has become. And any for any hospital, if you say the anesthesia services are good, so it cannot be there without a good acute pain service, ERAS, blocks, PCAs, epidural. So it has already been the core strength of us anesthesiologists. And I'll just give you an example for impact of acute pain service. For example, a thoracotomy patient who will avoid ICU because you just gave him a relevant block with an APS follow-up. So they can be mobile earlier, and you can avoid the damage which is because of the pain, because pain will not let the patient breathe properly, and as a result, the chest will not expand and the recovery will be greatly delayed. This pain can be because of the skin muscle trauma, the ligament damage, dislocation, neuritis, the chest drain, pleural irritation, shoulder pain, and anxiety as well. So this is just one example of surgery where, which is very common surgery which is being done all over, and such examples exist all across all surgical specialties and even in the critical care as well. Now I'll go towards the transition to chronic pain. So it's a kind of a cycle, and the exact mechanisms is not very clearly understood, but we of course know that what are the factors which lead to chronic pain. And one of these factors is, of course, poor perioperative control, which can lead to chronic pain as well. This is due to the heightened sensitivity to the pain, and which can result in reduced activity and social withdrawal. And through complex mechanisms, this can result in increased analgesic consumption, and there can be a vicious cycle which can then make the pain as a disease itself. So pain is unique. It is a symptom, is it is a sign, as well as it is a disease itself. So when I say a symptom, so I mean that this is something which will bring the patient to the doctor. So for example, patient had a fracture, and they are coming to the doctor. So the problem is, now you will not only treat the pain, but you will also treat the underlying cause. Again, another example is acute appendicitis patient coming to you, and you will not just give a nerve block and send him home. You will also treat the appendicitis, because you know that if you don't treat it, then it can have catastrophic complications. So in those situations, it's a symptom. Now, in some situations, it can be a sign itself. Now, same patient comes to you with tense abdomen, you just to press and check for rebound tenderness. So you have elicited this sign, and which also signifies that there is something deep below. But now imagine the same patient which I mentioned to you, but now they don't have any underlying cause. So they are having back pain, or they are having abdomen pain, and there's no cause. MRI is normal, everything is normal. So they have chronic abdominal pain without a cause. Now what has happened here? So here the pain has become the disease itself. In addition, if you say take some other examples, for example, low back pain where the MRI is showing normal, you're just showing some non-specific degenerative changes. Now, what do? In these cases, pain has become the disease itself, or the patient is having headache where you can't find any other cause. There is just a little bit of cervical spondylitis, and the patient is saying, "Oh yeah, I have full headache and I am not able to concentrate," and all those things are happening, and you are trying to find out, ascertaining, doing the various investigations, diagnosis. He's going from doctor to doctor. So in those situations, now the pain is no longer a symptom or a sign, but then the pain has become a disease itself. And if you see the ICD classification, it's the only uh, symptom other than the fever of unknown origin which is listed as one of the disease. So both back pain as well as headaches, they are listed as diseases itself. Now I'll introduce you to something which is very important for you to understand, because this has become now the tool for us anesthesiologists to fight against pain, and it is known as MIPSI, that is minimally invasive pain and spine interventions, which is the most cost effective and quickest method to treat pain. So it all started with the Indian Society for Study of Pain coming up with the coding system for a uniform nomenclature for interventional pain procedures, and which was also endorsed by the Society of Pain Clinicians. So it is these are procedures which are for chronic pain management. They are often curative, and I'm very happy to share that in this the our country leads the world, and they were published in May August issue of the Indian Journal of Pain. So just like, for example, you have the percutaneous coronary intervention by a cardiologist, similarly, you have the percutaneous spine interventions by a pain physician. So on the same premises, this was a kind of a classification, or to simplify, I will say it's a menu card for pain interventions. And we had various types of categories. So there were nine categories along with one miscellaneous group. And I will just give you an overview so that you understand what are the different uh, techniques which we pain physicians we use. And we have since we are anesthesiologists coming from anesthesia background and now doing all these variety of procedures, you'll be very surprised and pleasantly so that we have so much in our armamentarium. And it's very important to understand that because I am very sad sometimes to see that even our anesthesiologist colleagues are not aware that now pain physicians are doing endoscopic spine procedures, we are doing pain biologics, we are doing intradiscal procedures, we are doing spinal cord stimulator, and lots of very advanced procedures which were not easily available in our country a few years back. So let's go on to each of these categories one by one. So for the ligaments and muscles, we have these procedures which target the joints, bursa, tendons, ligaments, and muscles. We also have the listed codes for all of them, and this is very easily available through that paper. So these include conditions, treatment for conditions including knee pain, hip pain, shoulder pain, bursitis, subacromial bursitis, pes anserin bursitis, intermediate joint bursa interventions, minor joint bursa interventions, fingers, proximal interphalangeal joint, distal interphalangeal joint, sacroiliac joints, shoulder arthrograms, hip arthrograms. So lots of these procedures are available. Cervical facet joint interventions, lumbar and thoracic facet joint interventions, and also the radiofrequency ablation rhizotomies, which is the only definitive treatment available for the cervical, lumbar, and thoracic facet branch, this facet joint pain syndromes. So this is very good listing, and most of our procedures which we do here give lasting relief to the patient. It's not a shot and forget, but rather, especially treatments like radiofrequency ablations, they give very long lasting relief, lasting from 24 to 36 months. So that's a good time interval which patients gets. And more importantly, we do these under guidance of ultrasound as well as fluoro, and as a result they are very accurate. And these are covered in many insurances now. And you will be happy to know that most major cities have our pain physician network. Somebody is doing it in your city as well. So then we come to the nerves. This is the second category, and we do the right from the head to toe. There are various peripheral nerves which we target, including the greater occipital nerves, the lesser occipital nerve, third occipital nerve, most of them for headaches. Then we have the suprascapular nerve, which we target for shoulder pain. Then we have the intercostal nerves, which we target for chest wall pain. Some of them, these patients can be post-thoracotomy patients also, and others can be even herpes patients, and likewise. Then we have ilioinguinal, iliohypogastric nerves being targeted for, especially for post hernia surgery pain patients, and this can give a diagnostic block first, followed by the radiofrequency ablation or cryoablation, which we can do. And then you have the trigeminal nerve. So we are doing the trigeminal nerve procedures, including radiofrequency ablation, balloon compression. Then we have the sphenopalatine ganglion RFA, stellate ganglion RFA. So all these procedures which are listed here are being done. And you can see the huge list of procedures. In fact, there's a lot of sympathetic procedures which include sympathectomy, like the celiac plexus rhizolysis, or the thoracic paravertebral blocks, or the dorsal root ganglion, etc. And they also are very rewarding procedures for especially used in conditions like difficult to treat conditions like cancer pain, like CRPS, etc. So we use, I'm saying radiofrequency. So this is a specialized equipment which we used, and it includes an equipment where we have the nerve stimulator along with ablator system combined in one equipment. So the needle tip is specialized, wherein we can not only stimulate the nerve but also ablate it. In addition, epidurals, which all anesthesiologists do, they are used therapeutically, and the interlaminar epidural, all of you are doing already. But then this is the most important category, which is the transforaminal, cervical, thoracic, and lumbar, and even sacral epidurals are being done. And this involves placement of the drug very close to the target, which is the pathology, and as a result we get very good relief with these patients. In addition, the adhesiolysis, which is being done after, especially after a failed spine surgery, which is very commonly seen nowadays, is one of the constituents of this category. So you can see here we are using a dye. It is similar to actually this is the same dye which cardiologists will use for angiography. Only the difference is here we are using it for a neurogram. So you can see this is subpedicular approach, and this is the Cambian's triangle approach. And you can see the needle tip which is reached here, and you can see this neurogram, and you can see this dorsal root ganglion which is clearly seen. And as a result, this you can see this outline of a dorsal root ganglion, and this is the exiting route at this particular level, and we can easily target these nerves, and a result is pain relief for these patients. Now we also do fracture management. So traditionally, you will think and laugh, oh, fracture is the job of an orthopedic surgeon. But here, the management is not by a plaster, but rather you are going to put in a needle. And I think there is no better person to manipulate the putting of the needles than an anesthesiologist. And you can see that with the help of this needle, we place a small cannula through which we can put in the liquid cement. This cement is not like the one which is used in hip arthroplasty, which you all of you are familiar with, which instantly solidified. But this is a very different type of cement which takes its own time to solidify, and it gives a long lasting result in patients who have the collapsed vertebral fracture because of various causes. So it can be a osteoporotic vertebral fracture, or it can be because of a neoplastic disease also, or maybe in some cases trauma as well. So we not only do the traditional vertebroplasty, but we also do the kyphoplasty, where we inflate a balloon. So instead of just putting in the cement, we put in a balloon first, we inflate, we create a negative space like how I have shown here, and then we put in the cement. And it's very rewarding procedure. You can see this picture, AP and lateral. We can do it at multiple levels as well, and it's a very advanced procedure, but quite safe if done under trained hands. In addition, the next category is neurostimulation, and this includes the spinal cord stimulation, dorsal root ganglion stimulation. So, to simplify, it is kind of a pacemaker for the nerves. So, you must have heard about the pacemaker or actually, as most of your, or rather, all of you are doctors. So, and that too, anesthesiologists. So, I'm very sure that you are knowing very well what is a pacemaker. And this is a pacemaker for the nerves. So we can put it either centrally or peripherally. So when we put it centrally, we can put it in the epidural space just next to the spinal cord, and we put leads with which has got multiple electrodes depending on the model, which is connected to an impulse generator which is implanted inside the patient's body. So this is done after a trial, and trial means it's just like पहले इस्तेमाल करें फिर विश्वास करें. So it's something like you get a taste of whether it's going to work or not. It's kind of a diagnosis that your patient will benefit from this procedure because it's an implant and you don't want to take chances. So we put a spinal cord stimulator, and if the trial is successful, we implant the impulse generator in the patient and the pain goes away. The principle is that it generates impulses which has multiple mechanism, one of which is inhibition of the ascending impulses, and another one is for example, is inducing translational changes at genetic level, wherein the pain systems are modified. Okay. So the a more advanced version of the spinal cord stimulator is a dorsal root ganglion stimulator, wherein rather than putting it in the epidural space, we can thread it to the particular dorsal root ganglion so that the coverage for that particular nerve is achieved. And this treatment option is also very good, but the only thing is it should be done with trained hands. In addition, we have the sacral nerve root stimulation, peripheral nerve stimulator trial, as well as lead placement. Here in peripheral nerve stimulation, we place the same lead in the peripheral nerve. For example, if you are going to stimulate this trigeminal nerve, you can put it next to the trigeminal nerve, and then you can do it. If you can do the same thing for occipital nerve as well. And it started with failed back surgery, so you often will see this kind of patients with back pain. So the surgery is successful, but the patient still has pain. So in those cases, what you can do is you can give a trial of the spinal cord stimulation, but this was the initial indication. Now the indications have expanded. We are doing it for resistant, for example, peripheral neuropathies, which can be because of diabetes, it can be because of the chemotherapy induced peripheral neuropathy, and many other conditions. So this is very important for us to understand. It's a very important tool in the armamentarium of a pain physician. In addition, this I think most of you must have read in the books in when they ask what are the different modes of delivery of the drugs. Very common question which is asked to the PGs, and this is what we also do. So we put in the intrathecal drug delivery systems. So this is known as intrathecal pump in the common language, and you can give a trial drug administration wherein you give just single shot in the intrathecal space, and if the patient gets benefit, now you know that this drug is going to work for this patient. Then you put in a catheter just like a VP shunt is put in similar way. I'm sure most of you as anesthesiologists would have seen a VP shunt procedure. So it's almost similar. The only difference is here you are putting it intrathecally, and then you are connecting it to this pump from within the skin. So outside the skin you don't see anything, but inside this thin catheter is there which is connected to this pump. And you can also refill it, and this can last for as long as the pump lasts. The average life expectancy should be at least 6 months to justify the cost of the pump, and it's not very expensive. The cost starts from say 3.5 lakhs and goes up to 7.5 lakhs. So it's a very good option which is available. This is the picture schematic diagram of this pump, and you can see the needle is to be put here to fill the drug when it gets exhausted. Think of it as a epidural elastomeric pump. Only thing is that you need to remove that after a few days, say 7 days, 10 days. But then this one you can keep it for years together, and till the battery lasts. Or you also have rechargeable ones as well. After the battery exhausts, if the patient still wants it, you can just replace the battery module. Then comes this intradiscal procedures, and they are also done with either the help of a needle or with the help of endoscopes. So for the intradiscal procedures, we this includes the discograms, the ozone nucleolysis, then we have the biacuoplasty, we have the nucleoplasties, and all these procedures they work on the principle of destruction of the innervation of or new innervation of the nerves, which which are the cause of pain in these patients. So we put two needles and then just run a current through them, and whatever is in between is ablated. And this is a simplified explanation of what it does. And all these are various techniques how we do it. And of course it is quite advanced, but we can do it safely. This is, for example, patient lying prone under local anesthesia. That means not even regional. So you can see the needle tips. We enter from here and we reach the disc, and this is the RF generator, which is just used to deliver this current here. And as a result, the posterior portion of the annulus becomes devoid of the nerve supply, and there is a reorganization because it's just proteinaceous material, and the patient gets good pain relief after the procedure. So now we come to the endoscopic or epiduroscopic procedures. Anesthesiologists were the pioneers in epiduroscopy, And I was very fortunate to have met Dr. Hevner when he was still alive, who was one of the pioneers. And this was flexible endoscopy or epidural which was being done by him. But then Young et al. Developed the endoscopic techniques, and now we are using endoscopy very routinely in our practice. So endoscopy gives us the entry point is the spine. So we enter the spine through either the transforaminal route or the interlaminar route. So wherein we can actually see all these structures and pathologies and actually take care of them. Whatever is the pathology, for example, there is a superior articular process which is bulging and pressing on this route. We can remove that. If there's a disc bulging here, we can remove that. If there is some osteophyte, we can take care of that. So whatever is there, we can see in very good magnification, and this is a very rewarding procedure if done properly. So we can do it with various approaches and at various levels. This is a simplified diagram showing a transforaminal axis, and you can see that with the help of a needle, the same Seldinger technique which we use for central line, it's almost very similar. And the only difference is that we are doing it for the spine here, and our target is the fragment. So basically, we are doing a targeted fragmentectomy, which is the reason for the patient's pain. And this can be very easily accomplished, and it's a percutaneous procedure. We don't go inside, we are just outside, and it's just a hole which we create, and we do everything through that. So that's what we do. These are the pictures showing the steps. The patient lies prone, we put in our needle guide wire. After that, we put in the dilator, the sleeve, then we check, and then we do this under vision, and it's after that the patient is relieved. This brings me to the penultimate category, which is the pain biologics. And I know it may get overwhelming, but then I wanted to emphasize what big ocean of opportunities you have as a pain physician to treat your patients. You're having the PRP, the BMAC, that is bone marrow aspirate concentrate, adipose derived mesenchymal cells, which we can put into major joints, bursas, including the knee, hip, shoulder, trochanteric bursa, subacromial bursa, etc. In addition, we can also put them in the joints like temporomandibular joint, AC joint, so various joints. The principle here is that we want to take care of the inflammation, which is taken care by PRP, and provide the growth factors again done by PRP. But in addition, we can also do uh, the uh, the regeneration, which can be done by the mesenchymal cells, which are available. Again, these procedures are done under ultrasound or fluoro guidance. And this brings me to the miscellaneous category. And if you see, this includes the prolotherapy, wherein we are using dextrose mostly, which is very commonly available, and we use it from 5 to 15% concentration depending on the indications. So if you see that there are various miscellaneous procedures like the trigger point infiltration, very simple procedure, but again very rewarding. So this can be used for myofascial pain, Botox injection, which can be used for patients who are having severe spasms, acupuncture with electrical stimulation, which can be used, diathermy can be used, and these procedures are also done um by physicians or people who are doing non-invasive treatments, like physical therapists. But in a clinic, in a pain clinic, you may find this equipment, because and even physiotherapists whom we work with closely in association with, so this can also be found. So this is just an example of how a trigger point looks in ultrasound. So we use ultrasound to diagnose this, and then we will put our needle inside it here, for example, and either do a dry needling or maybe do even a trigger point injection here, depending on what we decided for the treatment for this patient. Okay, so this is how we do it. So to summarize, it's a personalized treatment for all patients. It's a new branch, pain medicine. The physicians who practice this are known as spine and pain physicians. So from anesthesiologist, it is to a pain physician or spine and pain physician. So simply, most of us call ourselves as pain physicians, and we do all these minimally invasive procedures, which I have mentioned, like endoscopy, spinal cord stimulation, musculoskeletal procedures using ultrasound, etc. And of course, all these will have very good results for a patient. So it's kind of a transformation which happens. It's very different than what we are used to doing as anesthesiologists. So it's always a kind of a different approach, bringing relief to our patients through various advanced procedures. And as I mentioned, very similar to what a cardiologist does. The only difference is that we do it for the musculoskeletal system, for conditions which produce pain, and even we get referrals from cardiologists for non-cardiac chest pain when they cannot figure out what's the reason for the patient's chest pain, in spite of various scans, angiographies, and even angioplasties. So that's something which is common. I thought I'll show you some pictures and some of the procedures in short so that you have some idea. For example, this is a procedure which is known as the radiofrequency ablation or the cool radiofrequency ablation for the knee joint, where I am targeting the genicular nerves under fluoro guidance. And you can see this in the AP and lateral pictures, how I have done that. And I can also show you a short reel of the same. So you can see this is the knee joint with these needles inside. This is the RF probe, RF needles, just to give you a glimpse of what we do as pain physicians. A few procedures which we routinely do. It's a very common procedure which I do in my practice, and then we ablate it with the help of this radio frequency generator in the cooled mode. So that's very rewarding, and I think this activates the healing and modulates the inflammation. In addition, for example, we also inject the regeneration fluids. For example, I'm injecting the leukocyte poor PRP here, and this is a filter which you have seen, and this is I'm injecting this in the suprapatellar recess under ultrasound guidance, and you can see this very easy, simple procedure. And regeneration, it's not some magic, it's method. You need to be very, very, very accurate and particular. uh, it Because you design, as Steve Jobs said, design is not what it looks like. It's not about the looks, it's how it works. So you can have a very good iPhone, but if it doesn't work, it's not worth it. Similarly, regeneration is no magic, it is about the method, how we do it. So my journey into pain medicine was almost by chance, and in MD days, we I thought that my head of department. I was very fortunate to have a very dynamic head of department who was also my guide for my thesis submission, and she was very dynamic, and she still is. And I was used to see her, and I thought that is what pain is, or pain practice is. And But the real exposure to pain happened when I went to SGPJ Lucknow, again by serendipity, and I had postings in all the departments, and I came to know about pain medicine. Then I wrote entrance and got selected for the PDCC pain management in Banaras Hindu University in 2014. And my mentor, Professor Rastogi, he's always said to practice pain full time. And once I moved to Mumbai, I switched into full time practice from day one. And this was quite a good decision because I could devote more time to the practice, and hence my results improved greatly, and so did my patients. So it's this invisible doctor image changed, and as pain physicians, we cannot be invisible. Rather, we need to make the pain invisible. So precision, recognition, little different kind of satisfaction, and of course, making a difference with a difference. So that's what matters here. And this is an opportunity for anesthesiologists. Anesthesiology per se is a very satisfying branch. I've always felt that the person most in control of all the things, in spite of so much of chaos happening, is always the anesthesiologist. And there are opportunities in the acute pain management space as well. For example, acute pain service leadership, which is still required, a lot of research in pain teaching, and of course setting up the clinics, pain clinics, and of course diversification. And here I will say is the role of the heads of the departments of various anesthesia departments, so that they can encourage people to take up different specialties, including but not limited to pain management and pain medicine, and kind of grow these different disciplines under their department, so that patients can benefit, and also the doctors can reach their true potential. So as anesthesiologists, I'll just say that we don't just put patients to sleep, we wake them up into a life without pain. So pain is a very important part of an anesthesiologist's practice. And with these words, I thank you. So I think this is it from my side. Over to you, Mukul sir.
Thank you, Siddharth, for a wonderful overview of pain medicine, its possibilities, and a very encouraging talk for people who are still not in the practice of pain. I think it's very encouraging, and it also opens up eyes of lots of people who just practice anesthesiology and ignore the pain component, which is a very important part of our practice, which should be a very important part of our to say. Thank you very much for giving a very good overview and talking about various aspects of pain medicine, which is also, you rightly said in between that, many of your fellow people, anesthesiologists, are also not aware of what is possible in pain medicine. And that's very, it's maybe an eye opener for lots of people. Maybe people like me may be aware of what are the possibilities available with in pain medicine, but there are lots of people who are still not aware of what are the possibilities and how pain medicine has expanded, has actually uh, finally found a place for itself as a separate specialty. And as a result, we have got now DM courses running in different places. And we also have lots of other courses like fellowships, which are being run by people in Calcutta, in SGPGI, etc. The multiple places where BHU, of course, you mentioned BHU, where you did yourself also. So all these places are really flourishing. Actually, if you ask me, it is not easy getting an admission into a place like even Ganga, even for acute pain blocks. So it's not easy getting a place because suddenly there's a realization that it is very important to learn this part of anesthesiology also. Thank you very much once again. And on the behalf of the Indian College of Anesthesiologists, I would like to, Dr. Manjula wants to say something. Yeah.
Yeah, can I ask one question to Siddharth?
Yes, ma'am.
Siddharth, this is just for my knowledge and my colleagues' knowledge. They want to know how many tender points are existing in body and how you can release those tender points pain to do the normal activities of the life.
Yes, ma'am. So actually, what we do is we actually have to first try and understand what the patient's pain points are. For example, there is no particular number of tender points which exist in somebody's body, but if they are having pain in a particular portion, that particular portion, for example, knee or hip or spine or even head and neck, people can have various points which can be tender. So the name is self-explanatory. So tender points will be when you will press, for example, here the patient will have pain. So these are muscular pain points which are due to the lack of oxygen and nutrients to that particular portion of the muscle usually, and or rather I will say poor circulation. And when we do these procedures, it restores it. There is a term which is known as chronic widespread pain, and it encompasses many disorders but the commonly used term is a fibromyalgia. So these patients will have multiple tender points across the body in various quadrants, and for the diagnosis, we need at least these points to be present in the patient. And in those groups, we will have say 18, 20 tender points. But otherwise, usually patients will have tender points and localized area. For example, in knee, it may be in the quadriceps muscle, and for example in the spine it may be in the erector muscles. So that's it, ma'am.
Somewhere I read it, or I don't know, somewhere I heard it that total tender points are 42 in the body. Is it correct?
uh, no, ma'am,
42 in
technically
number.
it's not. No, no, it's
Correct.
not like that actually. So this is various types of these tender points which you are mentioning about probably is from practices like acupuncture and acupressure, which we are not basically dealing with. So we are more focused on uh, the Western medicine, wherein we find out the actual cause and then we treat it. And these systems which you spoke about, they are focused on for various other principles, for example G and other things. So I've gone through those systems, but unfortunately I've found little success with them so far. So that's it,
So
ma'am,
you
from my
mean to
side.
say the tender points are different and acupressure points are different, correct?
Ma'am, yes, but then it depends on whom you're asking. If you ask a person who's doing acupressure, then they will say different things. But as pain physicians, we don't do acupressure or we don't focus on acupuncture. So that becomes a different way of treating the pain, and it's a separate method altogether.
Okay, thank you very much for the clarification of our doubts.
Thank you, ma'am.
Thank you, Dr. Manjula. Thank you. And it was very nice that Dr. Manjula asked you some question, which was made it more interesting also, I think. And now, on behalf of the Indian College of Anesthesiologists, I would like to express my thanks to Clarnet, and specifically Shreyasi, who was conducting this program. My special thanks to Vineet for being the coordinator for this ICA program. And I would like to remind all the listeners today that the Indian College of Anesthesiologists is doing great work in terms of academics for anesthesiology. And I would encourage all of you to become members of the Indian College of Anesthesiology and take benefit of the academics which we conduct. Thank you very much. Good night, everybody. Thank you.
Good night. Good night.
Thank you. Thank you.
Nice
Thank you so
Thank
much,
to
you,
you,
ma'am.
sir.
sir. Thank you so much, everyone, for giving us the opportunity to host the session today. Thank you. With all your
Thank you.
permission, I'm ending the session over here. Good night.